I'm going to go ahead and get started because it's 4:01 and I can easily count from there. So everyone, I would like to thank you guys for having me. It's really great to be talking to a community of people that get what we're doing as far as the digital phenotyping and the type of data we collect. But one of the topic I'm going to be talking about is working with people, a clinical population mainly, of people who have substance use disorders. And, substance use in the United States is very criminalized, so a lot of the data we collect, there's always questions around, are there repercussions to the person? And so we just have to really be sensitive with this type of data that we collect. But I'd like to go into telling you about some of the studies that we do. So this right here is like typically one of my first slides that I like to explain, talk about is like, you can't manage what you can't measure. And so one of the things when we are working with a clinical population of people with substance use disorder is that we typically don't have good measurement. I mean, can you imagine trying to measure diabetes without HbA1c, or measure, blood pressure without a blood pressure monitor, or measure cancer without pathology? These are things you just wouldn't do. So the question becomes, for example, how can we measure risk of relapse, risk of drug use, risk of treatment dropout without having good measurement tools? Our lab, working with colleagues at Penn and Northwestern and Stony Brook and different locations, we've worked to kind of build this online system that allows us to easily distribute these studies as well as collect data. So social media language is our bread and butter, language-based. So one of the things that we built is a system that allows us to collect online data recruitment so people can easily get into our studies, and we can collect social media data. And also we can collect data from multiple devices like the smartphone, the Fitbit, and different wearables. Of course, you get different data from Android versus iOS, so that's always a challenge. Lately, I've just been seeing Android-only studies, but also the populations I work with, many of them don't have iPhones anyway. So saying that you're, excluding iPhone users is typically not an issue. The other thing is that we collect lots of multiple sensors, and you'll notice on here I have the keyboard. And we have started doing a lot of keystroke analysis and collecting keyboard as well as text messages. So one of the tools that we've built off of an open source platform is the ability to collect text messages. And we have two ways of collecting text messages. We can get past text messages, so we can get a one-time pull of your past text messages. Or you can put the app on your phone and we can get text messages outgoing only going forward. And one of the things that we built on the text message is we have, we can't tell you what to text, of course, and what not to text. While we don't get the number that you're texting, everybody gets a unique ID and a unique code for phone numbers. We have built a script that kind of like goes on the server as data is coming on and removes names, addresses, telephone numbers, things that look like a social security number, things that look like a password. So we kind of built that on top because, we don't want that data in that type of information in the database. And we also built on an ecological momentary assessment, basically a fancy way of saying a survey that we can send participants. So I just wanted to give you a little bit of some of the information about the types of tools that we've built either with people in collaboration, open source, things like that. So when we're talking about predicting substance use disorder outcomes, typically I'm talking again about relapse and I'm talking about treatment dropout, but also sometimes substance use. We have, you have to think, when you think about substance use, it's very dynamic, it's very heterogeneous, and it's about subjective experiences. A person can go from being not using drugs to something happen, a cue or a trigger or something, and the decision is made in a moment second to use drugs. And we typically call that a lapse, and then the continuous use would then go into a relapse. something could happen in a second and a person decide to, treatment is not working for them. So a lot of times these indicators are very minute by minute. And unfortunately, treatment is typically, is kind of the way treatment was 20 years ago or 30 years ago or 40 years ago. A lot of treatment is group-based. A lot of treatment is peer support, which I support. Little treatment is starting to become more medication-assisted. But the problem is treatment is when a counselor or peer is typically available or around, that isn't the time that the trigger or the cue is happening. So we have this mismatch of what to do. The other things is that we have a huge measurement issue in substance use disorder. Again, when measurement occurs. Typically, measurement occurs at intake. So a person is coming to you saying they want to start drug treatment. Imagine how traumatic already of a time that is of a person coming in and the stress level. And then you sit there and you do an interview of the last 30 days, 60 days, lifetime of substance use. That information we get, it's very questionable about how quality it is. And it's retrospective, and you're asking people, well, what are your triggers? You're asking them at that time to try to tell you and make sense of past behavior. Also, in substance use disorder, this is a very stigmatized domain, and there's a lot of preconceived theories about substance use that are still out there that we haven't tested. We just haven't, the discipline hasn't grown that much. Recently, we've just started talking about substance use being more a disease of the brain. Initially, people thought it was just will, just say no, and you'd be okay. So when we think about that, one of the questions that I had, to me it seemed like a really simple question because people post everything in their lives on social media, was can we predict substance use treatment outcomes based on social media language? So our lab, we really have been focusing on using social media language as a digital phenotype. And so we wanted to know, using pre-treatment, so this is language before entering treatment, can we predict treatment outcomes? In this study, we had 504 people who were in Philadelphia in community-based, Medicaid-funded outpatient treatment. So this was intensive outpatient and outpatient, so going into, 3 days a week type of treatment. Of this population, about 269 had enough language for us to analyze. This would have been a great study if I would have found differences between people who had enough language and didn't in treatment outcome, but we did. So the people who had enough language for us to analyze were just as similar as far as treatment outcomes as the people who didn't. So this is the study that we did. At baseline, so that was when people entered treatment, we collected their social media language for the 2 years before. At that time, also, we collected something called the Addiction Severity Index, which is like the gold standard of predicting disease severity. We ran our predictive models, basically BERT, and we then did digital phenotyping, language-based analysis. The goal, using only language before entering treatment, is to see if we can predict relapse, abstinence, and treatment dropout 90 days going into the future. So using a random forest model with tenfold cross-validation, you guys all know this is pretty common, we looked at the Addiction Severity Index, which was the worst at predicting treatment outcomes. And then we have the language base, and then we have the combination. And so this right here gave us really, we were very excited, so this worked. But one of the questions was, what is it in the language that was predicting treatment outcomes? People always think that it's people talking about drugs, which is rarely the case. So so thinking about the linguistic features that best predicted these outcomes, we noticed something, and well, it's here on the slide, but that the abstinent group, we saw a distinct pattern, and then for the dropout group, we saw a distinct pattern. But the relapse group kind of went back and forth. Sometimes they look like dropout, and sometimes they look like relapse. And so when you're thinking of comparing this, the question was, well, what's going on with relapse? Because initially we were calling this a relapse study. Well, when we looked at predicting relapse versus abstinence and dropout, we realized that we were doing a worse job at predicting relapse. And then it hit us, like, while we talk about relapse as being a main issue, so drug use, right, as being a main issue, if you're talking about treatment in a chronic disease, we don't really necessarily care too much about relapse. What you really care about is if a person stays in treatment. For a chronic disease, there are going to be bumps along the road, and that is something that we should understand and accept with substance use. What we want is a person getting treatment and staying in recovery. And as you can see, we did a much better job at predicting dropout. And so what we did is we decided to operationalize this a little bit differently. So instead of having kind of the dropout, relapse, stay in treatment, we were able to split the relapse group into relapse in, so relapsing and staying in treatment, and relapse out, relapsing and dropping out of treatment, which then of course could go into just a two-group analysis of dropout, staying in treatment, or dropping out. Okay, forgot about that animation. So one of the things, typically when you add a category, you do worse on your AUCs, but as you can see, no surprise, we did better with the 4 outcome and the 2 outcome than the 3 outcome. So this gave us indication that, you know, we really needed to look at relapse differently, and that is how we all operationalize. The important part of treatment is not about relapse, it's about treatment, but it just kind of validated looking at it that way. And when we think, so basically, we did a pretty good, I mean, going back, we were very excited by these AUCs. It's validated here, so and said above 0.7 is great. So we were really excited about these AUCs, and the next step was we wanted to look at, for example, what was it in the language that was being predictive, and not too surprising, people, you know, effective processes, positive, total pronouns, and people in religion. So looking at kind of, these right here is using Luke, so looking at religion, positive emotion, people talking about family, things like that were remember, pre-treatment, those were predictive of doing better in treatment or staying in treatment, not dropping out. And the thought of this is like, well, there's two things that could be going on, especially with the religion. A lot of the 12-step community programs are very, you know, higher power. So we don't know right now, is this about that, or is it more treatment matching? Is it that people who talk about God, talk about religion, talk about family and certain things, do they do better in these type of community treatment centers versus others? So now we're running a larger study that will take all different types of treatment and look at this. So take that, I don't want to say with a grain of salt, but just take it. So one of the questions about this is, what can we do with this data? So again, remember that we got people at treatment intake. We asked for their Facebook, if I didn't say that, we asked for their Facebook language. That was just like, remember that screen, it's really a click of a button, you just log into Facebook and we get it. Whereas the ASI is an hour with a trained clinician going through it and walking through, you know, with a person. So an hour with a trained clinician versus a click of a button. You probably know where I'm going with this. So this right here can give us, for example, one of the things we figured out was making a dropout risk score. So using, for example, information at baseline. So using that, we decided to use the ASI because no treatment center is going to get rid of the ASI. It's grounded. But let's say you had the ASI and you had their Facebook language and we have their demographics. These are just basic things that you would get at treatment entry. So if you had that information, and then we predicted out, we put people in 4 categories, from a low, 4 quartiles, from a low to a high. You notice that we could do pretty well at predicting who was going to drop out of treatment and who was going to stay in. So well that if using this model, we would have been able to accurately predict 79% of the people who were going to drop out by 90 days. I mean, there's 2 things to think about this. This can allow us to personalize treatment. So if you know in the beginning that someone is at high risk, we can give them more services. In a community-based center, it's really hard to get a psychiatrist or to get a psychologist. But if you know you have the high-risk group, you can take resources and try to tailor it or target or personalize it to the highest risk group. I mean, resources are limited. But one of the other things that we saw by this is that there was a big drop-off during that first 30 days. The first 30 days is key. A lot of researchers actually start after the first 30 days because you get that huge drop-off. But by 30 days, we see that large separation. And our ability to distinguish the treatment group, the 4 different treatment outcomes group, we can do that at 30, 60, and 90 days. Also, we have nearly all the individuals who relapse. Nearly all the individuals who relapsed but stayed in treatment were in the low risk group. And nearly all individuals who relapsed and stayed or dropped out were in the high risk group. So this model or this algorithm is doing pretty good, and we are at the point of testing it. So we have moved to, or testing it in a larger sample. We have moved to doing some smartphone sensor-based digital phenotype, and I'm just going to briefly go through this. We did a national study with about 2,700 individuals that we followed for 150 days, getting social media language. We did EMA for the first 30 days, and of that we did 300. We did a smartphone sensor study where we collected, all of this smartphone sensor data, and now we're making sense of all of that smartphone sensor data. But some of the things that have come out of it, these are preliminary results, is that we're able to, using keystroke data, we can detect days that are drinking days versus days which are non-drinking days for individuals. As well as the amount that a person is drinking on a day. So for drinking 0 drinks, 1 drinks, or 2 or more drinks, we're able to do that, predict that looking at keystroke data. This right here is a sample of individuals who have alcohol liver disease, and we're finding some signal and craving changes based upon location entropy. So, real quick, we've talked about this a little bit, but there are some real concerns with working with this population and the type of data that we collect. So on one end, we're really, really excited that we get data that's collected in real time, yet over the course of a person's life. So we eliminate this recall bias and all of those type of other things that, a priori types of views of substance use and recovery. That's eliminated. The research directly helps typically normally I'm working always with marginalized populations, but substance use is a very stigmatized topic. We get very granular information, allowing us to make some pretty good predictions, and the majority of what we collect is passive data, meaning that, you guys know what passive data is, this population. So we get passive data. But hey, hold up, right? The data we collect is on behaviors which are illegal and highly stigmatized, like people can go to jail. And the algorithms can be used for bad. For example, while I think you can use that algorithm to identify people who are likely to drop out so that you can give them treatment. Treatment centers are a paid type of situation, and they get paid more for the people who do well. So someone could also use this to actively select patients which are going to do well and take them into their treatment center. There's other things that could happen, of course, too. There isn't really a way to de-identify this data. Like, we can de-identify it by HIPAA, wink, wink, but this isn't going up on a registry. I haven't figured out a way that you can do that. And you all also know that I do work for the government. I'm kind of federalized, right? I work for the government, and just saying. Thank you. Real quick, I would like to thank my team. This is my team right now, and these are some of my collaborators, all amazing, and of course, my scientific director, Amy Newman, and of course, Nora, the institute director, and I'm funded by NIDA. Okay.
Thank you so much.
Thank you.
Questions?
The keystroke data thing is really cool. I was wondering, how accurate it is, or what validation you use to ensure that it's actually predictive of the drinking.
Sorry. So we have the keystroke data, and we also have EMA, where we ask people, so a self-report EMA, where we ask people if they consumed alcohol. And we've done some other validation studies with EMA versus actual like drug use, doing drug screens, and they're pretty accurate. As long as you aren't penalizing people for telling you the truth about substance use, they typically tell you the truth.
This was a fantastic talk, by the way. I really love the focus on the population, really seeing the human behind the research. I do have a question about your approaches with the natural language process.
Mhm.
One thing that most tutorials will tell you is that you have to stop words, which are sort of words that are sort of used as fillers and pronouns and directives in English, like be, a, and stuff like that. But you hadn't removed them.
Right.
They were fixed.
Right. So one of the reason, oh, sorry, I'm cutting you off. I got excited. One of the reasons is that we've seen in the depression and in the suicide, mainly in the depression, that those stops are very predictive of depression. So we keep them in because we've just seen that from previous literature with the depression language and comorbidity with substance use. So we keep it in. We've also seen it with NSSI, self-injury. They're very predictive. So we keep them in. Oh, sorry, do I have time?
You have time.
Oh, okay, go ahead.
Something that made me think of.
I'm sorry, I can't.
Oh, something that made me think of acoustic markers during some of these interviews. Is that a measure that you thought of?
We have, okay, so that is one thing I have not been using is microphone or measuring or getting the audio from client and patient. Nora Volkov would love for me and has been saying, you have to start adding microphone, and we are thinking about doing that in the next study. The problem, well, for doing it with a clinician and a patient is much easier, but doing it just in the wild is really hard because of wiretap laws. I don't know if you can sue me because I'm with the government, but I don't know. They could try. I'm not sure. I'm not sure what trouble I could get into with that.
You know, it's such important work, Brenda. It's amazing, this kind of work. So I was intrigued by the slide where you had 79% area of the curve, looking at social media for the prior 2 years, predicting 90-day dropout. What do you suspect? Now you've got this new study where you're looking at all these other smartphone sensor data.
Yeah.
What do you suspect will significantly add to that area?
So that is, language is our bread and butter every time. So we've done, so the national study with the 300, nothing is outperforming so far language. Yeah.
What about something like sociability? Because
Yes.
I'm
So
not in this space, but I hear people in this space talk about isolation and patterns of sociability that change when people are in and out of substance abuse.
yes. So we have seen loneliness, which was an EMA measure. So we would ask people about their loneliness and being lonelier than normal, lonelier than usual, and we are seeing that with alcohol use, especially, and also binge drinking. So we have a couple of papers on that, and that's kind of sociability of being lonely. And we're also seeing the loneliness with the ALD, the alcohol liver disease patient. That's an EMA measure. Again, so that's not a sensor measure. We are trying to figure out a way for sensors to be able to pick up social connectedness, and we kind of haven't really come up with a good, I mean, it's probably out there in the field, and hopefully someone in this room can help, but we haven't really been able to figure out a good way of doing sociability.
So can I?
Yeah,
maybe
please.
Allow myself one comment.
Okay.
And I'll tell myself to stop talking. So we've been using communication logs. So like I know my communication logs with phone, so you know like you have incoming
Right.
communication, outgoing calls and texts. And we should definitely talk more about this. But to the extent that one buys the argument that more and more social interaction is not happening with the phone, which I think is easy argument to buy, you actually may be able to pick very like time-sensitive signatures in changing someone's sociability. And we've done some work in mental health where you see a dramatic change in communication patterns on the phone?
So we have that data. We started with, of course, accelerometer. We haven't looked at the call log
Let's talk about that.
data yet. Okay.
It's time to speak earlier.
Thank you, guys.